Welcome to Resiliency Radio, your go-to podcast for the most cutting-edge insights in integrative and functional medicine. I'm your host, Dr. Jill, and in each episode, we dive into the heart of healing with personal transformation. As you know, we have amazing guests from the realm of medical doctors to psychologists to just integrative health professionals of all types. Today, I'm so excited to introduce my guest on one of my very favorite topics. So often I get asked the question, what's one of the most important things as far as health and healing? And always in the list of top three, if not the number one thing that I guard so protectively is sleep. And today we're going to dive into that topic and give you some really practical tips from an expert, a world expert, Dr. Sahil Chopra. And I'm going to introduce him in just a second. But guys, if you like this podcast, please be sure and hit subscribe, hit the bell so you get notified of new episodes, and be sure to leave us a review wherever you listen to podcasts. That helps us share this work with more people. So without further ado, let me introduce Dr. Sahil Chopra is a highly experienced medical professional specializing in several areas, including internal medicine from UCLA, pulmonary diseases and critical care medicine from Loma Linda, and sleep medicine from Harvard. He has a diverse experience as a physician known for his expertise in diagnosing, preventing, and treating sleep disorders. Dr. Chopra is the co-founder and chief medical officer at Empower Sleep. Empower Sleep provides sleep care online using continuous vitals from medical grade devices. He has successfully used longitudinal sleep testing to contribute to his patients' overall health and clinical outcomes. Dr. Chopra, welcome to the show.
Oh, thank you so much for having me. Super excited to chat today.
Yeah, me too. And I always love to start with story. So you have quite credentialed history with UCLA and Harvard. But how did you first get into medicine? Was that something you had always wanted to do?
I don't know. I think coming from an Indian origin, you're not given very many options of what you want to be when you grow up, and medicine, engineering, law, those are sort of probably laid out. And being the oldest in the family, I think uh, I was just told to become a doctor, and once you're told that, you just sort of go with the flow.
I
And
love
I think like over time you see the impact that medicine has on people's lives and how it can be helpful. And everyone has some kind of a personal story of a loved one who was impacted by some physician or uh, some sort of miracle, and then that vision sort of starts to become a possibility. And I think one becomes really interested in that field. But I think it was probably started just by the seed being planted by my parents.
That's amazing. Because it is so often we kind of accidentally fall into our pathway, and then all of a sudden we discover along the way the power of what we can bring to that. And clearly, you've done that with your niche in sleep. So you went, UCLA and Harvard and all of this. And how did you? And I'm assuming you started like pulmonary critical care, and then went into. Tell us the journey of actually how you got into the power of sleep and really creating the programs and protocols that you do now.
Yeah, it's I don't really know how we end up here, but I end up in the pulmonary critical care because I loved working in the intensive care unit. Um, for those of us who are trained in internal medicine, we always think of like pulm crit as sort of internal medicine on steroids.
Yes.
You know, intubations, chest tubes, tracheostomies, ultrasound. There's so much pathology and physiology that one gets to learn. And being sort of a geek for that, I gravitated towards the ICU. Um, One of the unique experiences of being in a pulmonary fellowship is that you take care of a lot of people who have like a breathing condition called sleep apnea.
Yeah.
And that was sort of my segue into sleep medicine. Um, Became really interested in, there was a couple of things that happened. I read this book called Why We Sleep
Uh,
by Matt Walker when
yep.
I was a fellow. I Fellowship itself was very busy, working 70, 80 hours a week in the unit. So you're kind of chronically sleep deprived.
Yeah.
So yeah, like being sleep deprived myself, becoming aware of like what sleep medicine is as a field, the importance of sleep, and then taking care of patients who have a sleep breathing problem like sleep apnea. I just became really curious about the world of sleep medicine and ended up doing a sleep medicine fellowship.
Wow. And then again, like I said, I think it's just, especially when we go into integrative functional medicine and like root cause and trying to actually reverse trajectory into a certain disease at the root. I mean, I would like for you to actually lay out obstructive sleep apnea. I think people may be surprised at how connected it is to hypertension, diabetes. Give us the lay of the land as far as how many things can be connected to uncontrolled and untreated sleep apnea.
Yeah, I mean, the way that we try to uh, emphasize the importance of sleep is the housekeeping process for your body.
Mhm.
And if the housekeeping process is broken, interrupted, shorter than what it needs to be, then your body's not going to function as well. And, as a byproduct of that, that means like every physiologic function during the day is impaired because of dysfunction at nighttime.
Yeah.
So, hypertension, Alzheimer's disease, stroke, metabolic syndrome, high cortisol levels, coronary artery disease, AFib, like that list can go, it goes on and on. And uh, so the higher the dysfunction of sleep, the higher the likelihood or the higher the correlation of having these other uh, dysfunctions in different organ systems, whether it's a stroke in the brain or um, uh, Alzheimer's, cognitive impairment, or cardiovascular disease, or AFib, or hypertension from a cardiovascular standpoint. That list can be pretty long, and these are just things that we know of, right? And I'm sure that if there was a way to measure other things, there will be other biomarkers that would be abnormal because of nocturnal sleep dysfunction.
Yeah, gosh, I've seen that in some of my patients with the most extreme, whether it's immune issues or,
Yeah,
like you
yeah.
say, cardiovascular. It's amazing how often this is at the root. And again, looking at root cause medicine, it really needs to be taken care of. What about causes of obstructive sleep apnea? We classically think about maybe someone who's slightly overweight and has an obstructed airway when they lay down, but there's many other ways, and even younger people. Do you want to kind of lay it out as far as what are the most common causes of obstructive sleep apnea?
Yeah, no, totally. It's we historically the picture is an overweight male who snores. That's like the classic picture of obstructive sleep apnea. But what we're learning is um, the shape of our head and neck, our craniofacial anatomy, our mandible, our maxilla, um, nasal obstruction, all of these things play they play a critical role in the development of like upper airway narrowing. And so obstructive sleep apnea could be a byproduct of, obesity, being overweight, too much weight on the neck, but it can also be a byproduct of a small upper airway
Mhm,
from an anatomical standpoint. And other reasons for obstructive sleep apnea could be like heart failure.
mhm.
It could be, people can be oversedated from a medication standpoint. So that list is actually quite long. And the prevalence of what drives sleep apnea changes with age. Um, as we get older, there are different reasons for obstructive sleep apnea than there are in a younger individual. So it's a little bit more complicated than that, but nonetheless, through a good history and a conversation, one can start to tease some of these things out.
Yeah, and that was going to be my question. I deal with a lot of younger individuals relative to the age-related obesity, diabetes, heart disease that have different airway issues and stuff. What is more common in like your 20s and 30s when you do have these sleep disorders? What are some of the things that are a little bit more unique than the classical picture of that older male that's overweight?
Yeah, chronic nasal allergies,
Mhm.
anything that impairs nasal breathing,
Mm,
whether that is any inflammatory process in the nasal passages like allergies,
yeah.
or it could be it's significantly deviated nasal septum, um, someone who is chronically a mouth breather, someone who has a lot of dental crowding that suggests that their mouth is smaller than what it could be. These are all like very common drivers of obstructive sleep apnea in young individuals. And then, you take ethnicity into account where someone who is of like Asian descent, Chinese, Taiwanese, Korean, the prevalence of sleep apnea in that population is much higher just as a byproduct of the shape of their face and anatomy. So like, all of these things
So
play a
many
pretty
things.
significant role.
It's so fascinating because it's my own history. I had severe enlarged tonsils and adenoids from like 0 to 5, and I was like breathing out of the mouth and no nose at all. And I ended up having them removed, which probably really made a difference. But because of that, and I never knew this till I saw a dentist years later in life, I had a very narrow by and large arch there, which I'm assuming came from that. And then I got an Invisalign, and it actually changed the shape of my jaw. And it's interesting because I really did notice a difference in sleep after all of that was done, even though I had become in my adult life a total nose breather, I didn't have any issues. Does that make sense in the sense of like a younger child with those issues? Would that, say I didn't have my tonsils or adenoids out, do you think I would have had a risk as a child like that for sleep apnea? Um,
Totally.
yeah,
Yeah, I'm
interesting.
not even gonna let you finish.
Yeah.
Yeah.
You're like, duh, of course. I
No,
didn't
not,
know all this, right? Yeah.
it's not even done. I think like I really appreciate you bringing this up because in the pediatric space,
Hmm.
um, I talk to pediatricians often, and mouth breathing is common,
Yeah.
snoring is common, but it's not normal.
Yeah.
It's not physiologic. It is just because it's common, that does not mean that it is normal. And because it's common, we think it's okay, but it's not. And when we start doing sleep testing in kids,
Yeah.
they may not have like florid apneas or desaturations, but the fact that they are sleeping in a state where their neck is sort of like hyperextended or they're diaphoretic or they're working hard to breathe or they're restless, these are all clues that they are not restoring in a way that they're supposed to. They're not sleeping in the way that they're supposed to. And these are all opportunities to intervene and um, allow them to have the sleep that they need so that they can function well, not be labeled by ADHD,
Yeah.
or
Right.
inattention. Like there's a lot of interesting like work happening in this space of like children and inattention who actually have that is actually driven by sleep disorder breathing. So thank you for bringing that up. I think there's a lot to dissect there.
No, I'm so glad too, because I think that a lot of the chronic sleep deprivation in a situation like that would absolutely lead to these either behavioral disorders or learning disabilities or ADD diagnoses. And if the parents and pediatricians are really paying attention, this could be totally changed or prevented. So let's just, for example, let's stop here because I think we do have a lot of parents that have kids that listen and want to know more information. Say a parent is here and they have a 7-year-old boy with sleeping through breathing through his mouth. He's really like breathing that heavy. He might stop breathing at night, a lot of congestion. What would be the steps? I mean, obviously, I had my tonsils and adenoids removed, and that was the difference maker for me. What would be kind of a workup that you might do with a kid that's mouth breathing?
At least two things. The and I'm excluding a consultation with a specialist right now, but just from a workup standpoint, I would do at least what's called a cone beam CT scan.
Hmm.
It's a sort of a three-dimensional view of the head and neck, where one can get a very clear sense of the upper airway. And when I say airway, I'm not referring to just
Yeah.
this the neck airway, but really like the mouth, the nose, the nasopharynx, oropharynx, the supraglottic airway. And the other thing I would do is like a sleep study.
Hmm.
These two things, when combined, can provide a lot of insights into what is going on. And that sleep study could be in a lab or it could be at home, just to get a sense of what's the health of this person's. Because what you're trying to do is with a cone beam, you're trying to understand what's the anatomy,
Hmm.
how is the anatomy playing a role? And then when you do a sleep study is kind of a physiology
Yeah.
test, a physiology measurement test. And now you're trying to see, okay, with this kind of like anatomy, what is the health of this person's physiology during the window of sleep? And then once you have both of these two things, then you can start to see things that you wouldn't be able to see otherwise.
Oh, that makes so much sense. And this is cone beam CT. I've had at dental offices, so I know understand exactly what you're talking about. Is that something a traditional radiologist would know how to read in the realm of sleep disorders, or is that something you or a specialist would look at?
Yeah, when you look at those reports,
Yeah,
the radiologists who read them will typically comment on that the airway is narrow or volumetrically smaller or that where there is some level of like anatomical disruption and they may say, correlate clinically for a possible sleep disorder.
got it.
And but they won't really say I don't think it's probably not intelligent to say that one has sleep apnea based on
Right.
that
Correct.
because when you're doing these cone beam CTs, one, neither are you asleep.
Mm-hmm.
Um, and the other thing is you're actually standing upright.
Mm-hmm.
So the forces of gravity are really not playing the role that they would if someone is on their back in a sleeping position.
Okay, that makes perfect sense. So the radiologist might allude to the fact that this anatomy could lead to, and I'm assuming we're talking like I said, an example 7-year-old kid, but this could be 20s, 30s. Like you probably with anyone with a facial issue as far as the anatomical structure, that cone CT could be appropriate as a workup, right?
Totally,
Yeah,
totally.
okay. This is great, really practical. So you've been in this world and you've obviously developed Empower Sleep and some of the devices. Tell us more about what does that entail and what are you working with in diagnosing and treating patients and bringing this kind of to an, it looks like it's an online place where people can actually do some stuff before they maybe see a doctor to work up. Tell us more about that.
Um, yeah, no, I think it's like a mix of all of the above.
Okay,
One of the problems with sleep medicine is that it's rooted in this one night sleep study.
right.
And this one night sleep study can either happen at home or it can happen in a lab. And if it's in a lab, it's not your native environment. If it's at home, like the argument is it's only one night of data, and like, is that enough information to really understand my sleep health? So I think that's one problem. The other problem that has happened in sleep medicine is uh, sleep testing has become sleep apnea testing,
Hmm.
which like we don't look at other tests that way. Like when I order an X-ray for a patient, it's not a pneumonia test
Right.
or a heart failure test. It's an X-ray, and it's up to me to decide what do I want to see on this X-ray.
Yeah.
Like an MRI of the brain is not a stroke test.
Yes.
So similarly, like a sleep study is not a sleep apnea test. You can identify sleep apnea, but it's really a measurement of someone's physiology from a cardiovascular standpoint, respiratory standpoint, autonomic function standpoint. Um, so there's a lot to be learned from sleep testing. And unfortunately, what's happened in sleep medicine is that sleep apnea, if you do a sleep study, it gets read as like it's negative for sleep apnea
Yes.
or positive for sleep apnea. But it doesn't tell, we don't really talk about the health of someone's sleep. So, you know, one of the things that we're doing is like looking at sleep tests in a much more holistic way, and then also doing them over time.
Yeah.
So instead of doing a one night sleep study, I want all of our patients to do at least like 2 weeks of sleep testing using these sensors that just sort of go on your finger. They've been distilled to something that just is super
Hmm.
tiny. It goes on your finger, and now you can get a better sense of what is the health of this person's sleep
Yeah.
over a period of time. And we also let the patients see their results in real time the next day. So instead of like a sleep study having to go to a sleep doctor to be read, the patients can see their results every morning in the app, similar to get how they get their
Hmm.
data from like a Aura device or a
Yeah.
Garmin or an Apple Watch. And then you take that and then you connect it to a cloud clinic of doctors who really understand sleep health and sleep physiology, who are like excited
Yeah.
about helping somebody improve their sleep. And that's essentially what Empower Sleep is. It's a mix of like home diagnostics across
Yeah.
time, sleep physicians who love what they do, who want to look at sleep in a holistic fashion, helping them achieve their goals of like better sleep, all from the comfort of their home.
Okay, wow. I love this already because this is such a bigger view. Like you said, we started with sleep apnea, which is classically what we think of as sleep studies, which is why, as a physician, that's where I went first. But it's so much more than that. And someone like me may not have sleep apnea, but I know there's a difference in my quality of sleep night to night, depending on inputs of whether what time I went to bed or if I had a light, shining in the window or all these kinds of things. What are some of the things that you're looking at? And well, let's start there because then I want to compare to a lot of people now have the Oura Ring, the Garmin watches, and they're getting this data, which I think is not always the most accurate. So I want to talk about what your devices do that they might not get on their wearables. But let's first talk about what are you looking at with these measures? What are you actually measuring?
We are able to measure number of apneic events
Mhm.
per hour. We're able to, and if you're interested, I can just demo what this kind of looks like.
Sure. Yeah.
But we're able to measure apneic events. We're able to measure sleep quality, sleep architecture, um, a very detailed, high resolution profile of heart rate and oxygenation. These devices have an accelerometer built in them, so we can understand how much movement somebody
Mm-hmm.
is having. Um, so it's essentially a sleep study, and it's not our sleep test. We've taken off-the-shelf validated tools,
Excellent.
and then built a layer of technology on top of them so the patients can now see their results.
Got it. So you have made it easily accessible to the patients. They have immediate feedback. And then you've also created a place where they can go on the cloud and get real-time information of what to do as an intervention. So is your clinic all physicians that are actually looking at this? Yeah, perfect.
Yeah, yeah,
Wonderful. Yeah, and you mentioned sharing. You're welcome to share anything if it's helpful. If you're
yeah, absolutely,
sure.
absolutely.
Sure. I think you'll
Uh,
find this
let me,
really interesting.
let me go ahead and share my screen
Yeah,
here.
I just did this. Beautiful.
Cool. Thank you, Jill. So this is like the every morning the patient wakes up and they get their sleep report. And like Garmin and Apple and like I've tinkered with all these different tools. They're
Uh-huh.
very powerful, but they don't really tell you if you have sleep apnea or not, and they don't quantify that. They don't really quantify like the fragmentation of
Yes.
sleep. They don't really quantify um, one's sleep quality in
Uh-huh.
so this is very important as a clinician. Like if you're taking care of someone who has a suspected sleep disorder to whom you're prescribing a medication or a supplement or
Yeah.
prescribing someone CPAP, like these are the things that we would look at to measure the efficacy of this therapeutic intervention, while also getting a sense of deep sleep, REM,
Yeah.
total sleep time. And the other really interesting thing that I really enjoy is like we also integrate with a patient's CPAP machine in case they're on it for whatever
Uh-huh.
reason. So now you can see what the therapeutic device is doing
Wow.
to the diagnostic data. So now you have this closed feedback loop system. The patients, we encourage them to journal different things, different supplements, peptides,
Yeah.
body, sleeping positions, so forth. And then they can sort of track these specific and very sensitive biomarkers over like, these 7-day windows,
Mm-hmm.
but they can also measure them over like weeks, months, and years
Wow.
for patients who are like on the platform for that we're to whom we're taking care of. So
Yeah.
you can see how someone maybe started off with a sleep apnea burden in like the 30s to 40s. You're in Denver, you
Yeah.
mentioned. So
Yes.
at altitude, there's a lot of sleep apnea.
Hmm.
And then you can see how like these numbers change over time. And one can sort of get a sense of like, why did that happen? Well,
Wow.
he was on CPAP. There were, woke up a couple of times. So like these journal entries
Yeah.
now start to tell a story of why one's sleep is getting better or worse over a period of time. And we can do that for like sleep quality, objectively over a period of time. We can do that for sleep stages. We can do that for fragmentation of sleep, which are all very important biomarkers to measure. And then what's really cool is um, us as like the treating clinicians can look at all of this data um, over a period of like say 180 days of data compressed over time to see what are the trends, like what direction are we headed in from
Hmm.
a sleep quality, sleep apnea, sleep stages standpoint, while having the ability to look at one night of sleep testing.
Hmm.
Where we have like sleep architecture, sleep fragmentation, what's happening to heart rate, what's happening to oxygenation, what's happening to movement, and the different kinds of events, both obstructive, central, how long they are.
Yeah.
We can measure the length of desaturations in seconds. And so, like, Aura, Garmin, they're very good consumer centric tools to give us a sense of like what's the overall health of someone's sleep, but it's not really like a sleep test on a nightly basis where there's a lot of actionable uh, data that I can use to give
Hmm.
someone recommendations of what to do and what not to do.
Wow, that is so impressive. I am so glad we had you share that because it just brings all to life what all is there. And again, for people out there who have Garmin or I've had both Garmin and Aura, I love the Aura, but the same thing. And I really like the real-time data because for me, even with the basics of the Aura, I find all the time I'm using my N of one of like, oh, I did the PEMF map before bed. Did I sleep better or not better? Did I put the blackout curtains on? So I'm always experimenting with myself and trying to optimize the sleep. And with this, so this sounds like it's a device. Do they rent or purchase it from you? Because they have it long term if they want it, right?
Yeah. So we give these devices to all of our patients in our clinic to
Okay,
keep for as long as they want to. We have like a couple of different programs,
got
different
it.
tiers, either they're monthly or annual,
Okay,
depending on the patient's goals.
got it.
And we encourage the patients to test night as frequently as they want to. And the other interesting thing is um, patients can connect their Apple Health
Uh-huh.
Kit from their
Yeah.
phone as well as Aura to empower sleep. So now, as a clinician, I can start to see the relationship of like HRV, for example,
Yes.
with what is happening to sleep, a sleep test, and so then it starts to paint a fundamentally different picture.
Wow, tremendous. Gosh, this is such a, and I, like I mentioned before we started the podcast, we have a lot of clinicians that listen to this. So for those of you out there who are docs like me, to me, this is really powerful. Let's talk to docs really quick because I want to know if I want to refer a patient, is it something I just send a referral to the website? Patients just jump on the website and sign up. How would that look? Say I have a patient who's interested in this.
Yeah, there's a button. If you want, I can show you. That wasn't the intention, but
Yeah.
you can just click in the provider section.
Okay.
Uh,
And do like a referral. Yeah, you can share if you want.
yeah,
If anyone's listening, because we do have a lot of clinicians who watch. And to me, this is fascinating because for someone who does functional integrative medicine, knowing your physiology, knowing what's happening, and then doing interventions and seeing the changes is everything to do with us getting patients well. And this is probably the most powerful intervention is great sleep. So I'm all,
totally. And so
yeah.
like you basically go to the provider
Okay,
section
beautiful. Got
and
it.
then you can refer a patient.
Okay,
And I
perfect.
strongly, recommend that if you refer a patient, refer the patient this way or
Sure.
via fax so
Okay,
that the patient then gets tagged to you
got it. Okay.
and then you
That's
can log in as a doctor to see your patient's data over time.
beautiful. That sounds
So
really helpful. Then you can
it's
see the changes. And as we do interventions, maybe we're doing a new supplement regimen or something, or changing something in that realm, or treating an infection. That's fascinating. So good. Um, and they can sign up for like a monthly or a yearly or kind of whatever subscription they want. And so as long as they have access to that, they'll have the device to use.
correct. Yeah. Yeah.
Cool. Uh,
Absolutely.
Is there much reimbursement for? I know a lot of the things we do are so worthwhile, and I'm assuming this is like direct to pay to patient, but do patients sometimes submit and get reimbursement from their insurances?
Yeah,
Yeah.
we can always do like issue super bills
Mhm.
for the sleep tests that get
Yeah.
read. We are in network with insurance for telemedicine visits.
Oh, beautiful.
So any visit that we do that can be reimbursed through the patient's insurance. But to be a patient of the program, it's either a monthly or annual fee,
Got it.
and that includes like unlimited sleep testing as a part of it.
Fantastic. It's so exciting to see this because I've long had the just like such a distaste for the classical sleep studies and what they provide and what they don't provide. And it's a way, means to an ends for those who truly have obstructive sleep apnea, but there's so much more. And especially in my realm with chronic toxicity, infections, complex illnesses, there's so much more. Let's
Yeah.
talk real briefly about hypoxia. We talked about like altitude. Are there any other things that patients might not know about or people listening might not know about that could cause hypoxia that's not related to sleep apnea, like central or otherwise?
Yeah. The way that we uh traditionally there's like four or five causes of hypoxia.
Hmm.
And I'm just speaking it from like a pulmonary
Yeah.
standpoint here. It's either that one is at altitude,
Hmm.
like the partial pressure of oxygen is reduced, um, or they are hypoventilating,
Hmm.
meaning that they are not breathing faster. They are not moving enough air with every breath, and that is like someone who might be overweight, obese, and they're not ventilating fast enough. Or there is what's called VQ mismatch, where there is some abnormality in the lung parenchyma itself, where there is insufficient amount of oxygen that's making it across the alveoli into the bloodstream. And then lastly, there's a thing called shunting. And shunting basically refers to blood not making it to the lungs. So the causes of hypoxia are sort of categorized into these like four different buckets. Um, but so like there's a very the list of each of these things is quite long, and
Right. I can
but
imagine.
like, the common conditions are like COPD,
Hmm.
asthma, chronic bronchitis, emphysema. Um, if someone's had a blood clot before, those are the more common causes of like low oxygen levels over a 24-hour day.
Okay, that makes sense. I deal with a lot of mold toxicity, and of course, that can affect inflammation, more of like an interstitial kind of process that prevents the oxygenation. This reminds me of going back to second year medical school of all the differential, because I remember learning all that, but obviously I'm
Yeah.
not in pulmonology, so it's good to have a refresher. Well, this is fabulous. I am really grateful because, like I said, this is a super practical thing, and this is the way of medicine is giving patients more information, and I think the more the better. So it's super exciting. Anything else coming with your company and with the devices? Anything like new as far as how they're measuring data or calculating, especially in the age of AI with all the ability to analyze this stuff in real time?
Yeah, no, we're always like looking to make improvements. I think these sensors are only going to get better over
Yeah.
time. And when you have a lot of information about someone's health,
Hmm.
like the health exchange, you have their medications, their comorbidities, their medical history, and then you have a month or 2 months or 3 months of sleep testing data. Um, and then you incorporate AI into the equation, we'll be able to see things that we were not able to see before.
Yeah.
And who responds how to what kind of modality, we'll be able to figure that out in a much more accurate way that is like radically faster than what it is right now. Because right now, you or I have to spend a lot of time getting a history, looking at the data, a lot of trial and error. But, as we're taking care of more patients, individual patients will start to fall into these different sort of clusters that can be phenotyped and endotyped in a way where there's a lot of self-similarity. And using AI, we can then start to predict like what modality will work best for what person and be able to step away from the guidelines of,
Yeah.
first line, second line, third line
Right.
therapy versus like if you have this kind of biology, this is what you should probably get.
Start with.
If you have this kind of biology, this is probably what you should get.
Fantastic. And lastly, we didn't really talk about interventions. I mean, there's a classical, but do you want to just go over for those who are curious, what would be like the classical interventions that you might do as far as treatment, CPAP, nasal? Give us just a little rundown on that.
It depends on what the problem is.
Hmm.
And if someone has, I'll just use this like umbrella term, sleep disordered breathing, in which upper airway resistance, snoring, sleep apnea kind of fall into. It really depends on the burden of disease and what sleep stage the disease is in, the body position,
Yeah.
and the amount of overall hypoxia. So, like, that's how we will think about how to approach the problem. But the solutions range anywhere between like a bucket of like things that are relatively conservative, like nasal strips, mouth tape, tongue exercises, side sleeping, nasal sprays to reduce
Mhm.
nasal inflammation, uh, to more prescriptive solutions like CPAP machines, dental appliances. Um, there are like a category of devices called uh, EPAP, expiratory positive airway devices that sort of go in your nose that when you exhale, it expands the airway, to tongue stimulation devices, to pacemakers for the tongue. And now there's actually prescription medications that change the upper airway pharyngeal muscle tone
Wow.
during sleep. And so now there will also be the possibility of using like drugs
Uh-huh.
for obstructive sleep apnea that we didn't have before.
Wow.
So there's a lot of different solutions, and you can like sort of stack these together differently for different people
Yeah.
to find a solution that works. But you need to be able to measure what's working and what's not to be able to build that stack. For insomnia, for example,
Yeah.
CBTI, cognitive behavioral
Uh-huh.
therapy, we do that in house, and that's like the foundation for anybody who has insomnia. But the list of supplements is sort of infinite,
Yeah.
and there's probably a handful of drugs um, that can be used to address insomnia. Uh, and the way to approach even like prescription medications in insomnia is, traditionally what used to happen is like, here's some trazodone, try this for 3 months and I'll see
Yeah.
you.
Right.
But now it's like, okay, here's trazodone, for example. Let's test for 15 days,
Yeah.
see how your sleep architecture changes. If it changes for the better, then it might be something worth considering. If it changes for the worse, let's try something else.
Yeah.
So, even these drugs can be precisely prescribed at the lowest effective dose to achieve the goal that you're trying to achieve. Um, for restless legs,
Yeah.
there's a couple of different medications like the gabapentins and the pregabalins of the world, to nerve stimulation devices from a prescription standpoint, and then there's a whole bunch of supplements and exercises that one can do. So how we approach it really depends on what's the problem,
Yeah.
and then one can come up with a solution that works for that patient.
Gosh, and what I love so much is in the old traditional way, you're going to do 3 months and then you might get another sleep study at some point. But this real-time data is just profound. And for me, it's a big aha. I'm already thinking of patients I want to make sure that they know about this. So thanks for the work that you do. One last thing is, what would be red flags as far as whether it's a sleep study or even someone coming to you? What would be, if someone's out there like concerned about severe sleep issues, what would be the big things we're like, you need to see someone right away that we should just make sure they know the kinds of things that you get really concerned about? And maybe it's not till you get the sleep study data that you actually see how severe it is, but I'm just curious if there's anything patients might want to know about severity.
Yeah, I think if I had to pick one,
Mhm.
unintentionally falling asleep. Okay, I think that's like the biggest red flag, that if you are like fighting to stay awake
Yeah.
during hours of daylight,
Hmm.
or in the process of doing some kind of a task, like talking to somebody, or um, driving, or at work, or if you like feel so sleepy that you need to step out of your area to go take a nap in the car, like these are really big red flags
Yeah.
that something is abnormal, because that's not normal.
Yeah. Good.
Um, and like I would say, like excessive sleepiness is uh, probably like the biggest thing, and then like in the next sort of category, I would say if you have difficulty with falling asleep, difficulty with sleep maintenance, not waking up rested, if you have any of those three things and they're happening like consistently,
Yeah.
despite you doing everything in your power to improve your habits and routines, then I would definitely like get checked out.
Gosh, that's great because I know a lot of my patients are struggling with that. So a really good list. Oh, well, Dr. Chopra, it's been a pleasure getting to know you more and hearing about Empower Sleep. I think we list the website, but just so that people can hear if they're driving or whatever, where can people find this information? Is it just empowersleep.com?
Yeah, that's correct. Just
Beautiful.
empower. Yeah.
Fantastic. Well, thanks for the work you're doing in the world, and it's been a pleasure getting to know more about Empower Sleep today.
Thank you, Joe. Thanks for having me. And if anybody has any sleep struggles, like you deserve better, and we would love for the opportunity to make it easy for you and get you the care that you deserve.
Hey, everybody. Thank you for joining me for another great episode of Resiliency Radio. As you know, you can find transcripts and full episodes at jillcarnahan.com or anywhere you listen or watch podcasts. Be sure if you're on YouTube, hit like, subscribe so you don't miss an episode, and that bell button will remind you when we have a new one coming out, which is every single week. Lastly, I just want to be sure you knew that two exciting things that I wanted to mention. First of all, our movie, Doctor Patient, if you haven't seen it, it's now free, available with ads at drpatientmovie.com. And it's now streaming on Amazon Prime. So if you're a Prime member, which who isn't nowadays, you can watch the movie there as well under Doctor Patient Movie, either drpatientmovie.com or Amazon Prime. And then lastly, I don't know if you knew or not, but I have a launch of a brand new line of beauty products, Dr. Jill Beauty. These are all available at drjillbeauty.com. Some of my very favorites here, collagen booster, the biopeptide serum. So be sure and check out drjillbeauty.com. Great thing to start your new year for healthy, glowing skin. I worked really hard on creating clean, beautiful products, beautiful packaging, and more importantly, safe for your health without toxic chemicals. So thanks again for joining me. I will see you guys next week on another episode of Resiliency Radio. Bye-bye.